Well, good morning, colleagues, and welcome to session 3 of module 1 of our African Union Smart Safety Surveillance Capacity Strengthening Programme. I'm Mick Foy from the MHRA at the UK's Medicines Regulator. If you can just bear with me because I seem to have lost control. Perhaps Alicia. Oh no, it's working, thank you. So as in other sessions, we are joined by other MHRA colleagues to take you through the next step. We've spent the last couple of modules concentrating on the importance of collecting good adverse drug or adverse vaccine reaction data. And in this session, Kate from our team, Kate Bateman, who is the therapeutic group coordinator, is going to take you through the importance of good coding of that data once it's been collected. That's really important for the good signal detection and analysis of data. As in previous sessions, we're using Zoom. The functionality is on the screen in front of you. We'd ask that you use the chat box for questions around technical issues that you might be experiencing, and any questions that you have could be entered, please, in the Q&A box that you can see identified on the screen. We tend to pick up these questions either as we go, if we can answer them immediately, or we'll pick them up in the dedicated Q&A sessions. As always, we're recording this session so we can share with other colleagues who are unable to attend. Again, we have attendees from across South Africa, Ethiopia, Ghana, and Nigeria, and also colleagues involved in the 3S, AU3S program. I'm not going to go over again because I think many colleagues have been in the previous sessions. But just to say that the MHRA are working with the African Union Development Agency in delivering these capacity strengthening programs. This, as I say, is still module 1. This is the last session of module 1. And I think we're just confirming dates shortly as we move into module 2, which will concentrate on signal detection and management. And then we'll have further modules through until around April time. So as mentioned, we've already had sessions 1 and 2 in module 1, where we've spoken a high-level introduction to pharmacovigilance and an overview of spontaneous reporting. And then earlier this week on Monday, we concentrated on the importance of data collection and the tools that we use for data collection, with a specific considerations given to how we collect data for vaccines, particularly given the current situation with COVID. So now we'll move on to good coding practices, and Kate's also going to talk through some really excellent examples to get you thinking about how best to code to the right MedDRA term. So without further ado, Kate, let's hand over to you and take us through good coding practice, please.
Thanks, Mick, and welcome everyone. Just by way of a brief introduction, as Mick said, I'm Kate. I'm a pharmacovigilance information coordinator at the MHRA, and I manage our terminologies team. So I manage a group of signal assessors who primarily look after our internal drugs dictionary and MedDRA. In this morning's session, this is what we're going to cover. So we'll go through an introduction to the key concepts of MedDRA, including some practical coding examples of MedDRA terms. Then we'll go through some examples of case studies where you'll have a chance to think about what type of information is important for accurate coding of these cases, and what information you might want to request from reporters to improve the quality of the reports and improve signal detection and signal assessment. Then we'll talk about the needs for quality assurance auditing of a pharmacovigilance system using the MHRA's auditing process as an example. And then at the end, we'll have time for a Q&A session. So in the first few slides, I'll give you some background on MedDRA, and we'll go on to talk about the importance of good quality data and go through some coding examples. From what I understand, most of you, if not all of you, have at least some experience of using MedDRA, so I won't be going into too much detail today. But just to note, there is a huge amount of training available on the MedDRA website. There are live webinars you can join, there are recordings of previous webinars that have been held, there's instructional videos, and all of these are quite often available in multiple languages. Sorry, having issues with the slides.
Sorry, Kate. I just
yeah.
wonder, are you able to turn yourself up a little bit? You're a little bit faint, and some colleagues have commented that the audio is not.
Yes, I will try and speak up. Hopefully,
I think that's
a bit
better. Thank you.
So I've included some links to the relevant pages on the MedDRA website. So these are included in the slides that you have access to. So you can go and find the training at a later time. For those of you who don't know, the name MedDRA stands for Medical Dictionary for Regulatory Activities, and it is a clinically validated international medical terminology used by regulatory authorities and the regulated biopharmaceutical industry. The terminology is used throughout the entire regulatory process, from pre-marketing to post-marketing, and for data entry, retrieval, evaluation, and presentation. This slide shows just some of the features of MedDRA, and I'll go into some of these in more detail a bit later, but it's a standardized terminology that facilitates data entry, analysis, reporting, and electronic communication. Those of you who are familiar with MedDRA will know that it's a very large dictionary, which allows for great specificity. As it says in the definition, MedDRA is international, and it's currently available in 11 languages. And it is managed by the MSSO, which is the Maintenance and Support Services Organization. As I said, MedDRA is a large terminology, so there are many things that it can do, but it's also important to understand its limitations. So it's not a drugs dictionary, it's not a medical device dictionary, and it doesn't include severity descriptors, for example. So there aren't terms for severe headache or moderate headache. As you may know, MedDRA is structured from lower level terms, or LLTs, which represent synonyms or lexical variants, all the way up to the system organ classes, or SOCs, which represent the anatomical or physiological systems. And in between, we have preferred terms, higher level terms, and higher level group terms. So these structural elements are organized in a hierarchical structure, in which LLTs link to a PT, which is linked to an HLT, linked to an HLGT, and a SOC. And a PT can be present within more than one SOC. And this is what makes MedDRA what we call a multi-axial terminology, as one medical concept can be represented within multiple SOCs. This allows grouping by different classification, which allows retrieval and presentation of those different data sets. If a term is present in multiple SOCs, it will be linked to a primary SOC, which allows for consistency in terms of the data output. So there are some rules for determining how the primary SOC is allocated. For terms which represent disease signs and symptoms, these will be allocated to the prime manifestation site. So for example, shortness of breath's primary SOC is respiratory disorders, but it also maps to the cardiac disorders SOC. There are, of course, some exceptions where a PT maps to multiple SOCs, and one of those SOCs is the congenital SOC, or the neoplasm SOC, or the infection SOC. These will always be the primary SOC. And when a PT is linked to more than one of these exceptions, they are prioritized in the order they're listed on the slide. So if a term maps to the congenital SOC and the infection SOC, then the congenital SOC will be the primary one. So this is just an example to show you that. So for example, the PT influenza maps up to the respiratory SOC through the pathway on the left. It also maps to the infection SOC in the pathway on the right. And as I said earlier, infections is one of the exceptions. So this is the primary SOC for the PT influenza. Now, I haven't really mentioned LLTs so far, but LLTs, the lower level terms, represent synonyms, lexical variants, and sub-elements. For example, as shown on the slide, arrhythmia NOS, arrhythmia, dysrhythmias, and the non-current LLT, other specified cardiac dysrhythmia, all map to the PT arrhythmia, which maps up to the cardiac disorders SOC. Another example of LLTs might be the UK and the US spellings of a term. They will both exist as LLTs and map to the UK spelling of at the PT level. So LLTs essentially allow for the most specific term to be captured that most closely reflects the information as provided by the reporter. In order to keep MedDRA as a dynamic and up-to-date dictionary, new versions are published twice a year. In March, there's a complex release, and in September, there's a more simple release, which only includes minor changes. Newer versions might include completely new terms being added, changes in where a term sits within the hierarchy, or changes or additions to SMQs. I'm not going to go into SMQs any further in this session, as they're well covered in the materials provided on the MedDRA website, but SMQs are the standardized MedDRA queries, which group MedDRA terms from multiple SOCs that relate to a defined medical condition or area of interest. And they were introduced to ease recognition of syndromes and data retrieval of relevant case reports from a MedDRA coded website, a MedDRA coded database, sorry. And they have various applications, including signal detection. So MedDRA is used for coding and electronic transfer of ICSRs. The use of MedDRA in Europe is mandatory for all structured fields that require medical terminology. So adverse drug reaction, medical history, drug indications and tests. Each MedDRA term has a corresponding 8-digit MedDRA code, which is what's used for transferring the ICSR information. And MedDRA terminology is also used within PSURs, signal detection, and within SPCs. As I said, MedDRA is used for ICSR coding, where verbatim text, which is provided by the reporter, is converted into a standardized MedDRA term. And the correct use of the standardized dictionary, such as MedDRA, is hugely important for all pharmacovigilance activities, as it allows us all to speak the same language. In order for us to speak the same language well, we have to have consistency in how we're using MedDRA to code ICSRs. So, for example, coding of ADRs should always be done at the LLT level where possible. As I said at the beginning, there's lots of useful guidance available on the MedDRA website, including a points to consider for term selection document. This gives guidance on issues such as choosing to capture diagnosis or diagnosis and reported symptoms within the ADRs. And neither of these is incorrect, but there should be consistency in the application of the chosen conventions throughout your organisation. So MedDRA, as it is used by the regulators and industry, isn't particularly patient friendly. For example, there's approximately 200 rash terms. So the MedDRA MSSO have created a patient-friendly list of terms which can be used on patient-facing platforms. So for example, we use the patient-friendly list within our Yellow Card mobile app. There are some issues that come with coding data. So for example, verbatim text can include ambiguous information such as congestion. So that could be relating to nasal congestion, liver congestion, sinus congestion. Cramp could be associated with muscle cramp or menstrual cramp or abdominal cramp. Similarly, cases can quite often include abbreviations and they might have multiple meanings. So when situations like these arrive, there may be other information within a case that could help to determine what term is most appropriate to select. But there will be situations where there isn't any additional information, and those coding the case will have to decide if there is sufficient information to make an assumption or whether a non-specific term should be used and further information collected from the reporter. To get the best out of MedDRA and use it in the most effective way, there are some key points to consider, which I'll highlight over the next few slides. Possibly the most obvious point is that you need to ensure your data source is able to provide high quality data and is accurate and unambiguous. You need to have a quality system in place so that you should develop coding conventions that are in line with the ICH points to consider and the system that is designed to promote consistency in data entry and retrieval. And you should also have an audit process in place to review this system. And I'll go into the audit process in more detail later in the session. By avoiding ad hoc changes to MedDRA, we can ensure that we're all using the same version and we're all able to speak the same language of MedDRA. As I said before, the convention that should be used is to select the lowest level term and the most accurate term that reflects the verbatim text. So how an LLT maps should be considered in term selection. And as you can see on the slide, the changing of just one letter can completely change the meaning of a term. Those of you who are more familiar with the terminology will know that there are some demographic descriptors included in MedDRA, and they should be used where appropriate. For example, fetal bradycardia, or male infertility or female infertility. When a specific medical concept isn't covered by a single MedDRA term, multiple terms should be captured to avoid losing that information. As it says on the slide, you should select terms for all of the reported information, but you should not be adding, inferring, or taking away information from the case. When we are coding ADR information, we are not concerned with a causal association. We don't need to consider causality at this point. We're simply capturing the ADRs as they have been reported. You may come across device-related events, product quality issues, medication errors, for example, and terms for these events should be captured alongside the associated ADRs using the most appropriate term within MedDRA. In order to perform accurate signal detection and avoid background noise in signals, where a diagnosis is reported alongside typical signs and symptoms, the preferred convention is to just classify the diagnosis. For example, if anaphylaxis was reported alongside difficulty breathing and throat swelling, it would be appropriate to just classify anaphylaxis. Conversely, if only signs and symptoms are reported without mention of a diagnosis, it would not be appropriate to add the diagnosis as an ADR. And I have an example of that here. So in this example, abdominal pain, increased serum amylase and increased serum lipase are reported. So each of these should be coded. However, even though these may be well-known symptoms of pancreatitis, it would not be appropriate to capture pancreatitis as an ADR unless it was specifically reported elsewhere within the case. And finally, in cases where a provisional diagnosis has been given, for example, if a reporter lists a string of common symptoms and says they think it was likely to have been a myocardial infarction, it's best practice to capture the provisional diagnosis of myocardial infarction as well as the reported symptoms to avoid losing that information. And ideally, you would then follow up with the reporter to get a confirmation of that diagnosis. So to cover some of the coding practices I've just gone through, I've included a few examples of reported terms and how they should be coded. So in this first example, anaphylactic reaction, rash, dyspnea, hypotension, and laryngospasm have all been reported. Now, these are all exact LLT terms, as you can see on the right. And in this example, we would just code anaphylactic reaction. As I said earlier, when we have a diagnosis and common signs and symptoms, the preferred convention is to just classify the diagnosis. In this second example, it's been reported that the patient experienced hyperkalemia with a serum potassium of 1.6. Now, the reference range for potassium is 3.6 to 5.2. So the measurement of 1.6 is actually a low level, not a high level. So the information that's been provided here is conflicting. So in this instance, it would be best to capture the serum potassium abnormal, as we don't know if the hyperkalemia element of the reported text or the result, the 1.6 is the incorrect information. So it would be best for us to just capture the serum potassium abnormal. In this example, the reported information states that the patient had retinopathy due to diabetes. If two conditions are reported in a combination within MedDRA, then the combination term is the one that should be selected. So here we would be wanting to capture diabetic retinopathy. In this final example, jaundice in a newborn is reported. And as I said earlier, there are some demographic terms available in MedDRA, and these should be used where appropriate. So in this example, it would be most appropriate to capture the, oh, sorry, I have skipped over an example and I'm talking through something that's not on the screen. Let me go back. Sorry about that. In this GU pain example, we don't have much information here and we can't infer whether they're talking about genitourinary pain or gastric ulcer pain. So in this instance, we just want to capture the pain and ideally, again, follow up with the reporter to get further information on that. And coming back again to this example of jaundice in a newborn, as I said, where the demographic term is available, we should be capturing that term. So in this instance, we can capture jaundice neonatal. So to summarise, MedDRA is a clinically validated international medical terminology for regulatory application. You should take care to create and apply coding conventions that are understood across your organisation to ensure quality and consistency. And by coding at the LLT level, you will support output at all levels of the MedDRA hierarchy. I think it would be best if we continue on to the next section and hold any questions and answers until the end, as questions might be answered in the next few slides. So we will move on to our example case scenarios. So in these next few slides, we'll go through some example cases that I have put together to cover some key scenarios. While we're going through these cases, it would be good for you to think about how you would code the information that's been provided and perhaps what information is missing from the cases that you think would be useful to help case classification and which would ultimately aid signal assessment and detection. So in this first example, we have on the screen some reporter details, patient details, suspect drug details, suspect ADR details, and other details that have been provided. In this first case, we have a parent reporting on behalf of a 12-year-old daughter who has taken amoxicillin and experienced dizziness and a headache. And the additional information that's been provided here says that the daughter had twice the amount of amoxicillin than she should have taken. This would be quite a sparse case with limited information provided, but these can quite often be the case. And so we have to work with what we've got and request additional information from the reporter where possible. So if we start by looking at the suspect drug details, we don't have any information about the marketing authorization that this drug has come from. We don't know what dose the child was supposed to have taken or what they actually took. So in this instance, all we can do here is classify by the substance amoxicillin. In terms of the ADRs, we have a bit more information to consider here. For dizziness and headache, we don't have any more information about those events. and they are exact MedDRA LLTs, so we can just classify those exactly as reported. In terms of capturing the medication error, we've been told that the daughter had twice the amount of amoxicillin than she should have, but in order to capture that information in the case folder, we need to answer some questions. So, for example, we need to consider at what point did the error occur? Was it a case of the wrong dose being prescribed by the doctor, meaning it was a prescribing error? Or was the correct dose prescribed by the doctor, but the wrong dose was dispensed by the pharmacy, in which case that would be a dispensing error? Or was it an administrating error? Perhaps the parent accidentally gave more than was instructed. We should also be looking for any information that might make it clear why the error occurred. If it was a dispensing error, where the incorrect product was selected from the shelf, is that because the packaging of the different doses is very similar and they're stored next to each other on the shelf? And in that instance, we would want to be following up for the brand information. If it was an administration error, was that due to confusing or unclear instructions in the leaflet or the box? Again, we would want to follow up for the brand involved in that instance. Or was it a case of the child getting hold of the medication and taking it themselves? In which case, was the product stored incorrectly? All of these points are important to consider in terms of selecting the most appropriate MedDRA term when processing the case, and also when following up for further information from the reporter, as this information will help signal assessment. In this example, there's very little information to help us answer any of these questions that I've just gone through. So in this instance, I would want to follow up with the reporter to clarify these points, along with any other missing information from the case, such as ADR outcome, concomitant medications, past medical history, for example. And in the meantime, I would choose a fairly general term for the medication error, such as incorrect dose administered. So as you can see, there are a lot of points that you should be considering as you're classifying these cases. If we move on to our second example, here we have a patient reporting for himself. He reports palpitations and bruising following an influenza vaccine. Again, this is a very sparse case. In terms of the suspect drug, all that's been reported here is influenza vaccine. We don't have any information about whether this is a live vaccine or an inactivated vaccine. We don't have any information to help identify and classify a specific product. So in this instance, we will have to just classify the generic term that exists in our dictionary, which is influenza virus. Similarly, we haven't been given any information on the batch number. For vaccine cases in particular, we would definitely want to follow up for the brand and the batch so that if any safety issues are identified, affected batches can quickly be isolated and recalled if needed. In terms of the ADR, we've been told that the patient experienced palpitations. We don't have any further information about this, so we would just have to code the palpitations LLT. The patient also experienced bruising. So we'd want to consider whether this was localized bruising to the vaccination site, in which case we would be able to capture the vaccination site bruising term from MedDRA. In this instance, we've not got enough information to determine that, so it would be best to just capture the LLT bruising and follow up with the reporter to confirm. Where the patient has experienced a vaccination site reaction, particularly if it's a more unusual, unexpected local reaction, you'd also want to consider if the vaccine was administered using the correct technique. This is also something that you could follow up with the reporter to confirm. In terms of following up with the reporter for information that might aid signal assessment, you'd want to consider if the patient had any medical history. Do they have any history of palpitations or a heart condition? Were the palpitations associated with anxiety relating to getting the injection? Has the patient had any flu vaccines in the past? Did they experience these reactions then? Do they have any relevant allergies? The time to onset is also important. For example, if the palpitations didn't start until several hours or days later, that would rule out any confounding by any needle phobia, for example. You want to be considering these kinds of points for vaccine cases and follow up for the information where it's not been provided, alongside any other missing information like ADR outcomes, concomitant medications, etc. If we move on to our final example, this is an example of an exposure during pregnancy scenario. So here you can see that a doctor has reported that a patient has taken dalteparin whilst pregnant. And in the suspect ADR details, you can see that the mother experienced osteoporosis and there was fetal bradycardia. Again, there are some specific points to consider in this type of scenario. So firstly, if we look at the suspect drug details, again, it's quite sparse. There's no brand information reported, so we would just have to classify by substance again. They have, however, provided a dose, so we can add that information into the case that we're classifying. So with exposure during pregnancy cases, firstly, we need to consider who is the patient. Who experienced the ADRs? Was it the mother or the fetus or both? In this case, we know that the mother experienced osteoporosis and that the fetus experienced bradycardia. So in this instance, we would create a second case for the fetus. It's also important to know who the patient is in order to classify the most appropriate MedDRA terms. So for the case where the mother is the patient, we could capture a maternal exposure during pregnancy term alongside the ADR osteoporosis. And in the fetal case, we would capture fetal exposure during pregnancy alongside the ADR fetal bradycardia. Similarly, if we know what point of gestation the mother and the fetus were exposed, we can be even more specific in the MedDRA term we classify, as there are MedDRA terms that include whether the exposure was before pregnancy or during the first, second or third trimester or during delivery. In this case, we don't have that information, so we would want to follow up with the reporter to find out the gestational exposure. For pregnancy cases, there is a lot of additional information that we would want that would aid signal assessment. As this example is a very sparse case, we would want to follow up with the reporter to get that information. For example, has the mother had routine scans? Have they showed any anomalies or concerns? Was the mother taking folic acid supplements? What was the mother's smoking, drinking status during pregnancy or before pregnancy? How are the patients doing now? Has the pregnancy progressed without further complications? If the baby has been born, how is the baby doing now? Was the delivery free of complications? Has the mother had previous pregnancies? Were there any complications there? Did those pregnancies reach full term? As I said, with pregnancy cases, there are lots of points to consider to aid accurate coding and to help with the signal assessment. And the points that I've raised are by no means an exhaustive list. They're just some key points for you to be considering. So the points I've covered in the last few slides have been related to those specific scenarios. So I mentioned that you would want to follow up for batch number for vaccine cases if it hadn't been reported initially. That doesn't mean that you're not interested in batch numbers for non-vaccine cases. It will just depend on the information that's been provided and whether it's relevant for that specific case. The points I've included on this slide may be more appropriate to any type of case, not specifically medication errors, vaccine cases, or pregnancy cases. And again, by no means, this is not meant to be an exhaustive list. Each scenario and each case will be different, but hopefully it's given you some points to think about in terms of coding your cases. So we've gone through some examples of what to code in your cases. Now we're going to move on to how you can audit that process, using the MHRA's auditing process as an example. According to guidelines in Module 4 of Good Pharmacovigilance Practices, pharmacovigilance audit activities should verify the appropriateness and effectiveness of implementation and operation of a pharmacovigilance system. We want to make sure, essentially, that what we're coding in our cases is a high enough quality to produce reliable signals. So at the MHRA, our QA audit was introduced in 2007 and coincided with the launch of our new and improved ADR database Sentinel. We wanted to obtain a baseline to determine where we were in terms of quality with the new system and work to improve on quality and efficiency. In our teams, we have approximately 18 staff that perform data processing, and this is split out into 3 steps. Step 1 involves inputting information to make the report valid. So this includes the drug, the ADR, the patient identifiers, and the reporter details. Step 2 involves input of all other information, so start and stop dates of drugs and ADRs, and tests, for example. And step 3 is the quality assurance step, to try and ensure that all data entered at previous steps is accurate. So each month we review 100 direct serious cases in our QA audit. This is made up of all of the fatal reports received that month, and the remaining reports are spread across reports from patients and healthcare professionals and across all different report types. So this will include paper reports, reports received through the Yellow Card website and the app, and reports received through clinical systems where our Yellow Card is integrated. We recognise that different types of reports may be more associated with certain types of errors, which I'll go into more detail in a couple of slides' time. These 100 reports are randomly selected and allocated among 4 signal assessors who are our most experienced and senior members of the team, who mustn't review a report that they themselves have worked on previously. Once all the reports have been audited and the signal assessors, team managers, pharmacovigilance information unit manager and the quality standards manager meet to discuss and agree on the results and resolve any questions that arose during auditing. The results are then fed back to the teams who will correct the errors and are able to learn from them. So at the MHRA, we categorise our errors to demonstrate the seriousness of the error. As the slide suggests, we use A, B, C to categorise these errors. With A being the most serious, A errors can potentially influence safety issues through signal detection. For example, if the drug is missed from a case, it won't be available for signal detection. A errors can mean that we provide data externally that's incorrect, including data published on our website, and in some circumstances, A errors can breach confidentiality. B errors can influence our assessment of the signals detected. For example, incorrect ADR dates can change the interpretation of a case. B errors can also influence the information provided on an ASPA sent to the MAH. And the C errors are the most minor errors and affect more administrative aspects. As the signal assessors review their allocated cases, they're able to log any errors they find on a formulated spreadsheet. This sheet will include the name of the reviewer and the name of the assessors who performed step 2 and step 3 of data processing. This sheet also contains the report type. This is important because we now have many different avenues for reporting. People can report via the website, via the mobile app. We also have Yellow Card reporting form integrated into clinical systems used in GP surgeries and in hospital pharmacies. Assessors will ensure that the number and type of error is entered onto the sheet, along with an error reason for each error being logged. As I said earlier, some errors may be more common in certain types of reports. For example, you may expect more procedural errors from paper reports, as this involves much more manual classification than other types of reports where some information is automatically populated. We then go on to calculate statistics from the results that we find. These are presented in graphs or tables where applicable and included in a QA audit report, which is circulated to all of our assessors. The report also includes discussion of the errors with a focus on the A errors and any recommendations that arise from the discussion at the audit meeting. The team are asked to take note of the recommendations and to classify any reports containing type A or type B errors. And where needed, our internal guidance will also be updated as a result of any audit findings. To summarise, I wanted to give you some points suggesting why our methods of auditing quality ADR processing works for us. We're able to have confidence in our data internally and externally. It also enables us to have further confidence in our signal detection and assessment processes and not to question the data we make regulatory decisions on. Our methods also allow us to have a quantitative measure of quality to aid individual assessor development and progression within the team. So we also suggest that assessors not involved in the audit come along to an audit meeting so that they're then able to understand the discussion and the thought process that goes on around the decisions that have been made. The monthly audit report produced and circulated to the team provides transparency across the team, and it allows them to acknowledge the work that we need to improve upon. And the auditing is also, in fact, time-saving. Although having the resource to perform an audit may be seen as challenging, auditing is a very useful at reducing the burden of time spent on classifying reports. The more knowledge the assessors have around the errors we see, the less they will make these errors and the more experience they will gain. And the higher quality of reports will also mean that we get less MAH queries where they are asking for classification of the cases. So auditing of pharmacovigilance systems will look different in different organisations, but hopefully the slides that I've provided will give you some demonstration of the importance of auditing and how it can look end to end. So that's all of my slides. I think we'll go back to a question and answer session now.
Okay, that was fantastic. Thank you so much for taking us through. I think there's a couple of questions that have come through, but maybe I wanted to ask you a couple of things about some of the issues that you've raised. I think you raised a couple. You got the hyperkalemia and the GU example in your earlier slides where there was quite sparse information, and you mentioned a few times in your scenarios around the need for follow-up. How successful is follow-up, and what do we do when we know that we don't always get the answer back from the patient? Timing's quite an important factor here, isn't it?
Yeah, I would say it's definitely a balance between asking for all of the information that you want that would help in assessing the report and balancing that with not bombarding the reporter with loads of questions. So we want to be asking the key questions that will really have an impact on how we assess the reports. In terms of the rate of response of follow-ups, it's hard to say. I think we do get a lot of responses. People that report to us tend to be interested in the process and are keen to help and keen to get an outcome. So I would say that we probably receive a good response from patients and parents and carers.
Of course, the earlier you ask for that additional information or clarifications, the better chance you have of getting a response. I think if particularly with healthcare professionals, the longer you delay, then they've forgotten that case and moved on to other things, and you're probably more likely to not get an answer if if the request for follow-up information is delayed. There's an interesting question here from Friday, which asks about vaccine reactions. Do we consider these ADRs or AVRs or adverse events. Could you explain the difference?
So the adverse events are not associated with a causality. We code everything that we receive as an ADR, so we are assuming causality in those cases that we receive. Does that cover the question?
Yeah, I think we see different practices in different organisations, both at regulatory level and within industry, where some do a causality assessment on everything at the point of entry into the database, and others, like ourselves, as Kate said, assume causality and maybe do that causality assessment more at the signalling end when assessing whether there is an association when we're reviewing a signal, rather than at a case level, and even within a case level with every event that may be reported. So we don't really determine whether we think it's an event or a reaction at that first stage. I think Becky Drinkwater's asked an interesting question, and one that has kind of built up to, maybe over the last couple of sessions, we've built up to this question around driving up quality at the point of reporting. So within the Med Safety app, who does the first coding? And Kate, I think what we've done at the MHRA and what we're encouraging others to do as they adopt the Med Safety app is to drive up quality by putting the MedDRA dictionary in the hands of the reporter. So they're looking at they're entering the correct term, so that we don't have to do that recoding that you've described when we receive it. Could you explain some of the benefits of putting the MedDRA terms in the hands of the reporter?
Yeah, so giving the reporters that terminology to use, it alleviates some of the problems with coding that I was describing in the slides. So that will prevent us having to make any assumptions. For example, with the GU pain example that I spoke through, the reporter would be selecting the appropriate term. So they would be selecting the genitourinary pain, for example, and we wouldn't then have to lose that specificity by just capturing pain when we code that information.
So I think it's important to maybe just explain further that MedDRA, as Kate has explained, is the sort of international agreed terminology for collecting medical terms. So this is for regulatory activities. A healthcare professional or a patient parent won't know MedDRA, will never have heard of MedDRA, and won't need to either. But if we can present the terms that they want to report in a user-friendly way, then they're, by unconsciously using MedDRA for the benefit of the regulator capturing that in the right way. And then we further go on to share that case with the WHO via the Uppsala Monitoring Centres database, back to the manufacturers, if we know the particular product in question. So capturing the right term, albeit that it's MedDRA and rather a complicated regulatory activities dictionary, the reporter has that in their hands without actually needing to know the ins and outs of the hierarchies and the wider use of MedDRA. I hope, Becky, that's answered your question. There is a question from Mafora. Is there a guidance document to assist in asking the relevant questions when doing follow-up? Okay, I think we have standard operating procedures and kind of good practice guides that have been that we use internally. How relevant are they to a wider public audience?
I think you would need to develop your own standard operating procedures within the organisation, so that you're following up on the information that you're wanting for those cases. Obviously, those as Mick said, we have the standard operating procedures, so they might include a flow diagram which suggests what type of questions you might want to ask in certain scenarios. Obviously, those are just intended for guidance, and each case is different, and it will depend on the type of information that's already been reported in those instances. But yes, I think those are conventions that should be organised within your own organisations to obtain the most relevant information for you.
I think there's also a balance, though, and we've seen this with some of the pharmaceutical companies that report to us, that they are really aggressive in their follow-up. They ask for every bit of missing information. And isn't there a balance between getting missing information and asking for relevant information that's missing? And I think there is a danger if you overkill on follow-up requests that you actually end up alienating reporters.
Absolutely. If a patient has reported for themselves and they get a letter back seeing 10 questions and they might not have the information, they might not know the batch number of the vaccine they were given, and so therefore they don't respond at all. Yeah. So it's definitely a balance.
I think particularly also with busy healthcare professionals who may be very diligent in their reporting, that if they are bombarded with requests, then it might put them off reporting again in the future. So there is a balance to be struck there, and I think there is some advice that can be given. We can consider that in the 3S program around sort of good practice for follow-up. Maybe that's subject to a further discussion at another time. A couple more questions have come in. I think the first one's easy. Under medication errors, please explain what PMH means. I think you said past medical history, Kate. So I think we're all guilty of using acronyms in pharmacovigilance and excuse me, regulation. So apology, PMH is past medical history. But Habtumu has asked, when coding, should we use the LLT or the PT?
So as I said, we should always be using the lowest level term that appropriately covers the verbatim text. So ideally, we want to be using the LLT, but in some instances that won't be possible, and it would be more appropriate to use the PT. And I think that would be covered in the points to consider in coding guidance on the MedDRA website.
Yeah, and I think you've provided some useful links, so I would encourage participants today to look at the slides that will be forwarded around and visit those links if you're involved in coding adverse reaction reports. Have a look at the very extensive guidance on the MedDRA MSSO website. It's really good stuff, and also there are a lot of training courses delivered by the MedDRA organisation that really dig deeper into this area. Then we got a question around terminology, really. An adverse event following administration of a COVID-19 vaccine. Would we term that an AEFI, an adverse event following immunisation, or an ADR?
So for us at the MHRA, I think we tend to use those terms kind of interchangeably. We use ADR in our kind of language to cover immunisations and drugs and medical drugs, not just one or the other. But yeah, they tend to be used interchangeably.
Yeah. Thank you. I don't know, Alicia or Mercedes, there's been a few questions come through about access to the previous sessions, PowerPoints and recordings. I don't know if anyone, if Alicia, you want to pick that up?
Yes, of course. Thank you, Mick. So I'd just like to ask any colleagues who have difficulties accessing the previous materials that have been shared so the recordings that have been made available. If you could post your emails in the chat function, please. We will resend all of the materials to participants again following this webinar. That's materials for session 1, 2 and 3. But if you're receiving any specific difficulties with downloading the recording, please put your email address into the chat function and we'll write to you directly via email. Thank you, Mick.
Thanks, Alicia. Okay, I don't see any more specific questions around coding, Kate, but we're pretty much up on time anyway. So I'd really like to thank Kate for your time this morning and your explanation of the importance of good coding. And again, thanks to the colleagues who have joined today and participated in this session. That closes module 1. We look forward to moving on to module 2 now, where we'll be getting into signal detection activities, and then further on to through the modules onto benefit risk assessments and so on. As always, we'd like you just to take a couple of seconds to complete this poll. Again, I think these are the same 4 questions, but if you could answer each of the questions and then you can submit, and gives us a flavour of how we can continuously improve the programme. Thank you very much.
Thank you, Mick and Kate, for the fantastic webinar today. Just to assure colleagues, as mentioned previously, the materials will be circulated along with the recording and the audio. We will resend the materials for sessions 1, 2 and 3 again, and we've had a number of email addresses come through the chat function, so we'll make sure that those are sent directly to the new email addresses. As Mick mentioned, this is module 1. We do have modules 2 to 5, which will be taking place throughout this year. The dates are going to be confirmed for those, and invitations will be circulated to you for these module sessions in the future. A very big thank you to everyone for attending the webinar today. We will leave the poll running for the next few minutes, but the webinar has now finished. I thank you very much for joining, and we look forward to welcoming you to the future webinars for the Africa Union Smart Safety Surveillance Programme. Thank you very much.